Great, thanks. So I think we'll get started. Welcome, everyone. My name is Susan Law. I'm an associate professor at University of Toronto at the Institute of Health Policy Management and Evaluation and the Long COVID Web Knowledge Mobilization Lead. I'm very delighted to welcome you today to November's webinar as part of our monthly series. And today we have two quite different talks, but all in the spirit of providing updates and ongoing insights into current research and activities across Canada to do with long COVID. So we'll start with a land acknowledgement. We wish to acknowledge this land on which the long COVID web operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Thank you. This is just a reminder that the purpose of these webinars is to share evidence-based information, research results relevant for decision makers, researchers, clinicians, patients and families, and the general public. Also to provide ongoing updates, spotlights on emerging evidence and scientific information about the activities of our national network. And thirdly, to contribute to reducing and managing misinformation about long COVID. We do have a code of conduct. The link is there at the bottom of this page. To note, we value highly the engagement around the science and its interpretation, as well as its application. A commitment to reasoned discourse, as stated in our code of conduct, comes with the responsibility for all of us to ensure that any comments or questions remain within the spirit of positive, constructive, and respectful discussion. So we welcome any or all questions and comments in this spirit. Few thoughts about logistics here. The cameras and mics are off, but please post your questions in the chat. We will pause for Q&A after each speaker and address as many questions as we can. And these sessions are recorded, and with permission from the speakers, they will be posted online following the webinar. And we always welcome your thoughts about how these sessions could be more useful to you. We have a very short feedback survey, which we'll post during the webinar. So please do take a few minutes just to provide some response and feedback for us. Thanks so much. So we'll get started now. We'd like to start by Danica Walitsky, who is in Alberta, and she is a PhD candidate at the University of Alberta and a health economist within the Institute for Health Economics there at the university. So over to you, Danica, and thanks for joining us today.
Hello, so I'm just going to share my slides. All right, can you see my slides okay? And you can't see my presenter view?
No.
Okay, great. So thank you for that introduction, Susan. I'm happy to be here. I am the presenting author for this presentation, but I am only one of many people who have contributed to this body of work. I do have a few other research, like colleagues for this research joining the call. And so if there's any questions at the end, I might direct a few of them to them if they have a little bit more information than I do. So I will go ahead. So my presentation, or this presentation, looks at the impact of post-COVID-19 condition, specifically on the nursing labor supply in Alberta. And then what we did with this research is we assessed trade-offs with return to work policies. So just a little bit of an order here. I'm going to just start with a background. So why is this topic important? I'll go into the objective of our research. I'll touch on key outcomes that we've produced. I'll go through the different methods that we've used to assess our objective, key data inputs. I'll go through the results that we've found and some of the key takeaways and conclusions. So why is this important? Well, right now we are in a health human resource crisis. There are increasing trends in undersupply of of healthcare workers, specifically nurses. This is due to burnout, sick time, increased overtime, voluntary attrition. At the same time, health job vacancies have been increasing since pre COVID-19 pandemic, and they are still higher now than they were pre-pandemic era. At the same time, this is important because nurse workforce shortages have direct outcomes on patient health. So some of the things that can happen here are, shortages can contribute to hospital bed closures, delays in medical care, reduced quality of care. And there's research out there that show nursing staff shortages have been shown to impact patient mortality. This is important because nurses represent the majority of healthcare workers in Canada. Now, considering these trends that started pre-COVID-19 pandemic, then we have the impact of post-COVID-19 condition. So we have a population that is under stress. We have under supply of nurses. They are at a higher risk of contracting acute COVID-19 condition because they're patient facing. They're coming in, they have more contact with people with acute COVID-19 condition. And at the same time, they're also, and then that translates to a higher risk of them developing post-COVID condition themselves, which, which makes the stress on the workforce even higher. So we have increased absences from work of nurses, difficulty returning to work due to the rigidity of existing return to work structures. So what we really focused on is how can we mitigate the impact of post-COVID-19 condition on this already stressed out, undersupplied workforce so that we can decrease the impact of negative health outcomes due to this supply decrease. So we assess different return to work programs, and what we did was we created a simulation model in order to assess the degree of productivity loss based on the flexibility of different types of return to work processes. So assessing this is one potential solution that can help decrease this impact of PCC on our healthcare workforce. Sorry. Okay. So I kind of touched on this already, but so the overall objective of our research is to explore the productivity impacts of return to work strategies, specifically for nurses with PCC. So we do this by assessing two key outcomes. So we assess the total amount of work coverage that would be required for nurses missing work due to PCC. And then we also assess the second outcome that we assess is the number of times a nurse with PCC needs to change their level of work. This is a characteristic that is common across different chronic conditions. So PCC is a good example of a chronic condition that just doesn't seem to fit within the return to work for many return to work frameworks. We have variability in different levels of symptoms and changes over time, and this doesn't quite fit with existing structures. So I'm going to dive a little bit into the methods that we used in order to assess this area or this question. So we really focused our analysis on trade-offs. So we have trade-offs between accommodating nurses' limited work capacity due to PCC from an administrative point of view, but then we also highlight the administrative and workforce challenges of continually adjusting changes in capacity for nurses. So, if someone requires a lot of different changes in their work level, that's an administrative burden, or that requires a lot of administrative and workforce capacity in order to accommodate that, to find someone who can fill the different fluctuating needs within that position. But then at the same time, um, we want to do everything we can within a policy or a structure to accommodate people with chronic conditions such as PCC, to allow them to work as much as they can and not have an additional barrier to work, that is the rigidity of, a return to work policy. So in order to do this, in true health economic fashion, um, we work with a lot of mathematicians and health economists, and so we like models and numbers, and so that's what we did to assess this question. So we created, and by we, mostly my colleague Karsten. I'll give him a shout out there. He created an agent-based simulation model. And so what he does is he simulates the emergence of PCC in nurses over time. And then we also simulate the loss of productivity in nurses over time using characteristics of um, nurses by site, and then of PCC specifically as the chronic illness. And then we applied another layer, which looks at changing the level of flexibility of return to work policies. And so we kind of look at all these things together, simulate them together, and look at how things move in order to really understand and break down the mechanisms and trade-offs between return to work policies, capacity to work, and administrative burden of accommodating chronic fluctuating conditions over time. So the first step in this is we use Alberta Health Services registered nurses data. So this included site level data, which is geographic data. There can be multiple clinics or hospitals included in each of these sites, but we had about, I think it was around 457 different financial sites across Alberta, and we had information stratified for nurse type. So this included 5 different types of nurses. So we looked at healthcare aide, registered nurses, licensed practical nurses, registered psychiatric nurses, and nurse practitioners. So throughout this, we do look at the difference across the different nurse types, across the different sites. We did have information by age, sex, and a few key demographics for each site. So then what we were able to do is take that information and generate a model that represents these site-specific characteristics across Alberta. So we supplemented this data with some published literature. Some of the key pieces we looked at are incidence of PCC and productivity loss due to PCC. Now, the reason why we focused on this too is going through PCC data and different research, there's not a lot that we found specifically related to healthcare workers, which are patient-facing and have higher risk of PCC. So this is kind of the link of why we're focusing on this. So what we do first is we take this data, we supplement it with published literature, and we ended up creating a time series of nurses and how they and projected, estimated their changes in work capacity due to PCC over time. So how we did this, first we take we calculated a ratio of nurses versus the general population from January 2020 to 2022. And this ratio is calculated using the acute COVID-19 cases and hospitalizations in the general population. So this is public data that we were able to use. Then we also were able to find the total number of acute cases in nurses. So we calculated this ratio difference of acute COVID-19 cases and PCC2 and cases over time to extrapolate PCC cases in nurses specifically. So we end up with this ratio. We apply it to cases and hospitalizations in the general public, and then we're able to extrapolate acute COVID-19 cases over time in nurses as long and from there estimate the proportion that would be suffering from PCC. Sorry, that did not come out that smoothly. So that's the first part of the data analysis. Second part of this is we estimate how this is going to translate, how this time series of nurses with PCC that we have, how this translates to loss in productivity or loss in work capacity. So what we did is we used what we call a random walk framework. So we assign different nurses within the model a varying capacity for workload. So one being their pre-COVID level of, or their pre-PCC level of work that they could handle. And then zero being they couldn't handle any of the work that they previously did before suffering from PCC. And then over time, we use characteristics of PCC in order to project ebbs and flows across different capacity of these nurses. And so we take into account duration of symptoms, types of symptoms, age and sex, kind of give an estimate of how capacity can change over time. From this, we estimate our two key outcomes that we talked about in the beginning. The total number of monthly work coverage required for nurses missing work due to PCC. And then the second main outcome that we quantify is the number of times per month a nurse with PCC changes their level of work capacity. So it's not just how much coverage is required, but it's the number of changes in capacity that contributes to administrative burden of accommodating someone with chronic condition. Then what we do is we layer on one more thing, which is different policy alternatives. So we looked at 3 different return to work policy structures. One we classify as restrictive. So we classify this as you return to the level of work that you were doing before suffering from PCC, or you don't return at all. We also have a moderate policy that we simulate, which is 25% increments. So you either do 0% of what you were doing, 25, 50, 75, or 100% of the work that you were doing pre-COVID-19, pre-PCC, I guess. And then a flexible policy, which we use 10% increments. So we allow we allow nurses within the model to work at 10% increments. So say whatever their position was before, they could do 0, 10, 20, 30, up to 100% of that existing position or the position that they were holding prior to PCC. So after we layer on all of this, we kind of assess the differences in work productivity loss over that time series of So we use monthly data over a 5-year period. So some key things, uh, some key notes about the data that we used. Some interesting things is the nurse workforce data that we used. We did see change in baseline nursing job characteristics. So this is outside of the model, but just to note, headcount increased from between 2018, so pre-COVID-19 pandemic, to 2023, so within the pandemic, headcount of nurses increased by a significant amount, 11%. The total full-time equivalent capacity of, or not capacity, the total full-time availability of nurses increased also 8%. But at the same time, we did notice the proportion of full-time equivalent nurses decreased. So we have more nurses doing part-time or casual positions. We did also see an increase in sick time during this time, which I think makes sense. But then we also see a huge increase in overtime, which is a little bit counterintuitive considering we have an increased capacity or an increased total full-time, an increased total availability of nurses and an increased headcount. So these are some of the underlying changes within the nurse workforce that we're seeing just in the data that we're using. Some key notes also is that we used pre-Omicron data for our estimation of the impact of PCC on nursing productivity into the Omicron era. There was pretty limited data for us. And so what we did is we used a probabilistic one-way sensitivity analysis. And if you don't know what that is, that's okay. It's just a way for us to um, test the uncertainty around using these estimates. So what we did was there's two key estimates that were from pre-Omicron era. So the risk of PCC following acute COVID-19 infection. What we did was we decreased that by 50% after into the Omicron era to see how that would impact our results. And then we also decreased the probability of nurses with PCC missing work due to PCC. And so we kind of play with that a little bit to see how much our results change, taking into account that um, our estimates from the pre-Omicron data probably overestimate the nurse workforce productivity impacts. All right, so I'll quickly go through results. I see that I'm almost at 20 minutes here. So here we look at we simulate over time the productivity loss. So the first graph, this is the monthly coverage required to cover nurses missing work due to PCC. So, and each of the different lines are kind of the changes in the different restrictions in the return to work policies that we tested. So here we can see the green line at the top. This represents the work coverage required under a restrictive policy. We can see that it does require a lot more coverage to fill in the gap of nurses missing work due to PCC under a restrictive policy. And at the same time, the red line is our most flexible return to work policy. So this is the 10% increments of a previous position. And we see a lot less coverage required to fill in the gaps with a flexible policy. Now, the second graph below, this is the number of changes in work capacity over time. So this echoes very similarly, but opposite. So the flexible policy, which allows you changes in your work position in 10% increments, results in the most number of monthly changes of workload. And at the same time, the most restrictive policy you have less changes in your working position capacity over time. And so the second graph, what this captures is there's going to be a lot more administrative burden, um, accommodating a flexible schedule because we have all these different changes in work level versus a more restrictive policy. So this is kind of the trade-offs that we looked at the model. So the previous slide, I guess we'll go back. So this represents nursing time and nurses. Now, at the same time, this result is financial site specific. So this is the 457 sites across Alberta. Um, and then we have different nurses assigned under each of these sites. And so here we look at under these different policies, how are the financial sites affected? So here we include any financial site missing over 10% of their labor supply due to PCC. So the top graph, this shows that in a more restrictive policy, we have a lot more financial sites with a significant proportion of decreased labor supply. So this is over 10% for each of these sites. Now, under the flexible policy, we're seeing a lot less labor supply shortage at this, but in the top graph. And so, sorry, in both graphs. But one thing to note is there is a bit of a difference between urban and rural. So the top graph looks at urban sites and the bottom graph looks at rural sites. So the Alberta Health Services data, the financial state data, they have markers that indicate whether or not they classify it as urban or rural. And so that's what we used, kind of split to see the difference here. And so here we can see just a little bit of a change between the two. Now, I know I'm running out of time, so I'm going to jump to our conclusions. So some of the key takeaways from our work is that the variation in work capacity over time plays a very big role in return to work programs. So it's not just the level of work that someone can do or their capacity, but the number of times it changes plays a big role in labor supply, specifically in nurses. So, and there's two key things that need to be considered with return to work programs or accommodating individuals with chronic conditions such as PCC. So we need to consider the number of work hours that needs to be covered, at the same time, the number of times that this needs to be adjusted. And so these both contribute to the administrative challenges of accommodating return to work processes. And the third takeaway for us is that we're able to quantify the return to work policy trade-offs. This can provide some important information for policymakers in weighing the trade-offs between mitigating the decrease in labor supply, but then also how much capacity or time and administrative burden is there in accommodating it. So this is what we did with our research and our analysis. Hopefully it was somewhat clear. I know it's probably a little bit different than the other presentations here, but I'm open to any questions that anyone has and any specific technical questions I might refer to some of my colleagues.
Thanks so much, Danica. I just wonder if Ellen or Karsten want to say anything now? Just as final comments. We have time for one or two comments. Yeah.
No final comments. I think Danica described this really well. It was kind of an evolving project as we went and figured out, what what PCC looked like, the impact on productivity, what the nurse workforce looked like, and what options there were for return to work. I think we had a lot of discussions with the whole team about, how could we represent return to work policies in this type of model, which I know is very complicated because these models really need to simplify things, and there's so many nuances in return to work policies that we can't capture. But we heard that this was the biggest thing that we needed to capture, was how often people this kind of were looking to return to work and their capacity to have productivity, and so that's kind of where we focus at based on that feedback that we got from both people with PCC as well as people working within the healthcare system and looking to provide these return to work to options, as well as people working within rehab and what they were seeing with their PCC patients. So we really appreciated that feedback.
That's great. I don't see any questions in the chat. Oh, sorry, Karsten, is there anything you wanted to add? Hopefully his mic is turned on. I'm not sure. Okay, Carson, you're welcome to put anything in the chat if that's helpful. But I just did have a quick question. I just wondered how you said you were talking to people working in the system, and this was kind of a modeling exercise, but also how closely were those policy options matched to what's actually happening on the ground in Alberta, for instance, in healthcare provider institutions?
Oh, and sorry, I will come back to your question, but I just got a note from Carson. He's not able to unmute.
Oh, okay. We can ask our colleague Nick to help with that.
You want to take on the question, Danica, or you want me to go?
Yeah, if you can go, that'd be great.
Yeah, so that, like I said, that was a big point of discussion. So we actually met with some human resources people within Alberta Health Services to discuss, both what they were seeing. One big element that came out was that they couldn't identify people with post-COVID conditions or long COVID. So that was really tough for them to know how much this was impacting their population, if how these people were progressing within return to work, whether return to work was working with them. But one of the things that came out of the conversation was, okay, when we're representing return to work policies, it is really important to represent kind of the number of shifts, because that is really administratively burdensome for them to try and deal with. Is people who come back for a while and then go on leave, or they have different levels of capacity. Being able to represent that was kind of highlighted as a key element. So that's kind of how we decided to focus on that for this conversation. But one thing we do want to highlight with this project is the gaps for people trying to do these return to work policies, is not having that information about the people that they're trying to develop them for. I think it's been a big gap for them.
Great, thanks. Karsten, any quick final comments?
Yeah, just to mention, just picking up on this data paucity issue. We went as far as we could given the data we had available to us, or as far as we felt that we could go. And there are other aspects of return to work that we chose not to try to quantify in our model, such as changing positions. There's or changing venues, or these kinds of things like respecialization into something like adjacent. First, there are issues with getting data on that, given what Ellen had just talked about. But also it's a little more complicated, and we wanted to minimize the assumptions we were making. So we stuck to things that we could quantify, but obviously there are other aspects of return to work that are also important for long COVID.
Great. Thanks so much. Very important work and important to help support our people making policy and trying to provide services when their staff are ill. So thank you very much. There is a question in the chat. I wondered if perhaps one or all of you could address that while we turn to our next two speakers. So I'd like to welcome now. Thank you so much anyway for that presentation and for your work. That's terrific. So we have now Dr. Chris Mushquash and Crystal Hardy, who are both from Lakehead University. And Chris is a psychologist. He's a Canada Research Chair in Indigenous Mental Health and Addiction and a professor at the Northern Ontario School of Medicine University. And Crystal is presenting some of her work as her master's for her master's degree, and Chris was her supervisor for this. So welcome to both of you. Thanks for joining us, and I'll turn it over to you two.
Thank you so much. Can everyone hear me okay? Can you hear me okay?
Good to go.
Okay, perfect. Anim buju, Camino Gijagan, Sagabanakwe, Indishnikas, Mukondadem, Vinjituavik Saging, and Ishnavek Donji. So, hi everyone, thanks for having me here to present. Today's presentation is called From Crisis to Sovereignty, First Nations Pandemic Leadership and Resilience During COVID-19. And as you said, these are findings from a qualitative study on pandemic preparedness and response in First Nations in Northwestern Ontario. Next slide, Chris. The quote that opens this presentation comes directly from a community leader who participated in this research. They reflected that in the midst of COVID-19, people put their differences aside, and that's always been a strength of this community. And so this quote really captures the central phenomenon illuminated in this research, and that is the mobilization of collective strength and cultural continuity in the face of systemic failure. And so the COVID-19 pandemic revealed deep inequities across Canada, but for First Nations in Northwestern Ontario, these inequities were not new. They were the visible outcomes of entrenched colonial structures that continue to divide access to health, housing, and infrastructure. And so this study sought to move beyond describing disparities and move instead toward critically analyzing how self-determination, governance, and cultural cohesion operated as mechanisms of survival and strength during a global crisis. The findings demonstrate that First Nations governance is not merely a supplementary system of care, rather, it's a central determinant of effective public health. Next slide, Chris. And so a little bit of context about what the pandemic exposed. The pandemic served as an acute stress test for Canada's tripartite health governance model. First Nations across Northwestern Ontario experienced the same pattern of repeated delayed funding, inconsistent communication, and an absence of coherent coordination between federal and provincial systems. These gaps amplified the existing determinants of health inequities, which were overcrowded housing, water insecurity, limited healthcare infrastructure, and chronic under-resourcing of rural and remote First Nations, to name a few. But there were not simply logistical failures. These were structural outcomes of colonial policy frameworks that continue to shape how health is administered rather than governed by First Nations themselves. And so understanding pandemic vulnerability therefore requires situating these inequities within the broader colonial determinants of health, a framework that acknowledges how policy, jurisdiction, and governance intersect to produce predictable patterns of risk. Next slide, Chris. So a little bit of an overview about research purpose and methodological approach here. This qualitative research was designed to critically examine pandemic preparedness and response and mitigation across 4 First Nations in Northwestern Ontario. The central research question asked, how were First Nations both supported and underserved? by federal and provincial governments during the COVID-19 pandemic, and what forms of autonomous community-led response emerged in the absence of coordinated government supports. And so 14 Anishinaabe key informants participated in the research, including chiefs, nurses, health directors, and pandemic response leads. So using grounded theory within a transformative framework, this study sought to describe experiences and to generate a First Nations-led conceptual framework for public health response, and one that centers sovereignty and relational accountability. The resulting emergency response model that you'll see later on in this presentation represents a synthesized structure for culturally adaptive and self-determined pandemic governance. Next slide. So the first theme, colonial barriers to safety. Across all participating First Nations, there are two dominant categories of barriers that emerged. And these were structural failures of the tripartite health system and the compounding effects of social determinants of health. So participants described funding that arrived months into outbreaks, inadequate PPE distribution, and inconsistent directives from both federal and provincial agencies. As one community health rep recalled, with the first wave of COVID-19, we lost one husband and one wife in the same day. They would still be here if they'd been placed somewhere safe. And on the screen, you'll see a picture of those two individuals who were lost. Inadequate infrastructure and policy fragmentation forced First Nations to rely on local capacity rather than coordinated government supports. And these findings really underscore that colonial fragmentation rather than geographic remoteness singularly is the true barrier to safety for First Nations pandemic response. Next slide, please, Chris. So the tripartite model, where federal, provincial, and First Nations authorities share the governance responsibility, functioned as a site for jurisdictional paralysis. Participants described this as a jurisdictional fog, where accountability was diffuse across multiple agencies, none of which held decisive authority during times of imminent need. And so one chief recalled that pandemic directives were filtered through three separate languages that are three different systems that didn't speak the same language. And this model reproduces what can be called a form of bureaucratic colonialism, one where responsibilities are perpetually deferred while First Nations bear the full weight of consequence. Next slide, please. Here we have theme 2, which is cultural strengths that saved lives. So in sharp contrast to systemic barriers, the study revealed that cultural strength, rather than government intervention, was the principal determinant of resilience. Community solidarity, guided by the 7 grandfathers' teachings, became a public health ethic. Acts of care, such as firewood deliveries, food distribution, water provision, and daily wellness checks on households of elders and those who are vulnerable, were organized locally without reliance on external instruction or oversight. And these actions were not merely community gestures. They were evidence of functional First Nations governance systems operating parallel to and often in spite of external structures. And as one leader stated, we had to help our own people no matter what. And on the screen, you'll see a picture of members from one remote First Nation traveling by skidoo to bring supplies to another First Nation hundreds of kilometers away who was in crisis and in need of food and water supplies. And so it's just a testament to the collective care. Next slide, please, Chris. One of the other strengths really was leadership and Anishinaabe nursing. The presence of trusted Anishinaabe nursing was consistently identified as a key facilitator to effective response. Community nurses served as both medical and cultural intermediaries, translating biomedical directives into relational practice. In First Nations, when leadership modeled transparency and trust by publicly receiving vaccinations, for example, uptake and acceptance increased. And so this finding affirms what prior Indigenous health research has demonstrated, and that is that trust and relational continuity are measurable determinants of health behavior and compliance. Next slide, please. Now we're at theme 3. And this is primarily what emerged from the research, and that's the blueprint for the First Nations First framework, which was an emergency response framework. And so the First Nations First framework synthesizes the 7 interrelated dimensions of effective First Nations pandemic governance as they emerged from this research. So the first dimension was culture, which formed the ethical foundation for collective action. The second dimension was context, which informed structural and historical conditions, shaping vulnerability. The third was preparedness, which are locally developed plans grounded in self-determination. The fourth was communication and coordination, which determined information flow rooted in trust and community networks. Then there was surveillance, which were developed relationally and community-based monitoring mechanisms. And then was response, which were the adaptive strategies guided by collective and biomedical knowledges in the communities and the First Nations. And finally, there's reconstruction and recovery, which was an important part of the emergency response system, and that was healing, restoration, and system redesign post-COVID. Next slide, please, Chris. And again, we have a quote from another key informant. This is an attempt at a visual representation of the model that emerged from the research. But the quote is, "We figured it out on our own." And that was a strength in itself. So this framework provided both an empirical and theoretical contribution to Indigenous public health, operationalizing sovereignty as an evidence-based determinant of system effectiveness. Next slide. Preparedness and rapid adaptation. Preparedness across participating First Nations was uneven. So very few possessed updated or relevant pandemic plans going into COVID-19. Many had outdated documents from the H1N1 pandemic or had developed plans from H1N1 that had no bearing on the COVID-19 context. And so within days of imminent need, however, First Nations leaders and community members mobilized local task forces, repurposed facilities as isolation centers, and instituted lockdown protocols where necessary. Command centers were established autonomously, manually tracking cases and needs. And these emergent systems demonstrated a remarkable capacity for innovation and governance agility, attributes that were absent in many of the government-directed response frameworks at the time. So the contrast was pretty incredible. Government systems froze and bureaucratic delays, while First Nations took immediate action in real time. Next slide, please, Chris. And next was surveillance and innovation. Community surveillance was grounded in relational accountability rather than technological infrastructure. So mediums such as social media, Facebook, and other tools were used to communicate to members cases across the community. So many First Nations implemented a color-coded household card system as well, with red signifying isolation, yellow indicating a need for assistance, and green marking all clear. And so these cards would be put up in the window, as you can see in the house in the photo. And that would be an indication to pandemic teams who would travel around the communities in order to assist members who needed it. Social media and radio became central information networks, facilitating real-time coordination across households and neighboring First Nations. And this blending of systems of collective vigilance with modern communication tools really illustrates First Nations innovation, which was adaptive, efficient, and deeply human-centered. Next slide. Reconstruction and recovery. So post-COVID, recovery revealed the deep psychosocial toll of sustained emergency management. First Nations reported escalating grief, burnout, and substance use. Elders described pervasive exhaustion, a reflection of prolonged vigilance under conditions of necessary isolation. And as was stated by one individual, if you're in a crisis, you don't always know how much you're traumatized. And so recovery, therefore, must extend beyond biomedical metrics to include spiritual, cultural, and communal restoration. Mental health and grief supports grounded in culture were repeatedly identified as essential cornerstones of holistic recovery. Next slide. And so lessons for future public health emergencies. I think findings from this research offer several actionable imperatives. First is to develop and fund First Nations specific pandemic plans informed by local governance structures. And so those plans will differ depending on each First Nation's distinct needs. Eliminate the bureaucratic delays embedded within the tripartite funding mechanisms. Next is to embed self-determination and data sovereignty within all emergency response systems. We also need to integrate culturally grounded mental health and grief recovery frameworks as core rather than peripheral elements of public health response. Because these aren't merely recommendations of goodwill, they're evidence-based prerequisites for equitable and just crisis management. Next slide. So the connection to long COVID, the lessons from COVID-19, I think, have direct implications for emerging chronic conditions such as long COVID. The same jurisdictional fragmentation and data invisibility persist, leaving First Nations patients undercounted in surveillance systems and underserved in care pathways. So the First Nations First framework is one of many examples of a structural roadmap for addressing these gaps, advancing continuing care, culturally responsive community communication, and integrating data systems under First Nations governance. So long COVID exposes the same colonial scaffolding really that hindered pandemic response. And the solutions, therefore, should also be reflected rather through sovereignty, trust, and relational accountability. Next slide. And so I'd like to wrap up with a final note from one of the individuals who participated in this research. And that individual said, we didn't leave anyone behind. Everyone had a purpose in our societies. And I think this closing reflection encapsulates the moral architecture of the First Nations First Framework, as well as the First Nations who participated in this research. It reminds us that success of pandemic response in these First Nations was not incidental. It was intentional, and it was rooted in self-governance and collective care. And so COVID-19 reaffirmed a truth that health systems have yet to institutionalize, and that is that sovereignty is a public health intervention. So when First Nations governance is empowered, public health becomes more than crisis management. It becomes relational, just, and sustainable. Next slide. And that's it, Miigwech, thank you. And my email is on the slide if anyone wants to reach out, has any questions afterward.
Thank you so much, Crystal and Chris in the background there. But this is absolutely fabulous work and very well presented. Congratulations on all that, and really, really important messaging, I think, for anyone and all involved in the pandemic response and in long COVID. So, Chris, I just wondering if you have any comments before we turn to any questions or other comments?
No, nothing to add. Thank you.
Okay, terrific. So a question from Leo. I'm curious if you can comment on how these community nation level responses have changed over the course of the pandemic. I know lots of folks are resistant to the idea that we are post-pandemic because the virus is still circulating.
I can't actually say whether anything's changed post. Like, I've shared the information with the communities, so there may be some adaptations, but I don't know specifically about these 4 First Nations if anything has changed.
Okay, thanks. Great. And I guess I'll just ask what's next for this work? How will you share this and get it where it needs to be?
So far, I've given it all back to the communities, of course. So it's an iterative process. We've presented at a bunch of conferences, working on publications at the moment, to try to get it, try to get some policy reform implemented. And so we have a few policy suggestions that we're working on.
That's terrific. And do you have an idea of how this mirrors or sort of converges with other findings across Canada in similar communities or areas?
Yeah, at the time when I did the research, there wasn't a lot of work on specifically what I was looking at, which is the tripartite supports in First Nations. I don't think there's been a lot since this research either. Yeah.
Okay, so nothing to compare with really, but perhaps
there may be some work in BC, but I know their structures are different in terms of connecting with First Nations and how there's the funding structures and the federal structures are set up. So BC, I think their First Nations health system, they have a self-governance system, and so they have a little bit more power and autonomy in their processes. But that's, yeah, so that's something to strive for, which is great.
Yeah. Well, really excellent and important work. So thank you very much.
Thank you.
I'll just say thanks to everyone. Nick, I don't know if you can whip the little questionnaire we have in the chat, but thanks very much to our presenters and to all of you for participating. And if you do have feedback for us, don't be shy. Well, I wish you a great rest of week. Thanks so much for attending today.